Hi, I'm Mark. Welcome to this series on evidence-based medicine. It's designed for doctors at all stages, students, doctors in training programs, experienced doctors, and GPs. In the series, we're going to look at the evidence underpinning the therapies which we use every day in clinical practice, the risk factors for the conditions which we encounter, the science behind our screening and diagnostic tests, and we're also going to look at other concepts like overmedicalisation. Today, we're going to discuss the basics of evidence-based medicine. What is it? Why does it matter? And how can we practice it every day in clinical practice? Let's get into it. What is evidence-based medicine? It is the science component of clinical medicine. We engage in tens of thousands of consultations in our careers, and in every one of those consultations, we try to diagnose conditions in the present time. We consider risk factors for conditions that might develop in the future. We weigh up the pros and cons of therapies and share them with our patients. And sometimes we try to screen for conditions which haven't clinically manifested yet. Those four clinical concepts all derive from clinical studies which we need to understand. At its heart, evidence-based medicine is about making the best clinical decisions for patients using these three components. Firstly, your clinical experience and expertise. Secondly, patient preferences. And thirdly, the best available evidence. We accrue more clinical experience over time. Through continuity and listening to patients and experience, hopefully we can delve into and understand patients' preferences. What about the evidence bit? Well, it is our professional and ethical duty as doctors to understand the evidence base behind our therapies, our diagnostic tests, our screening tests, and our risk factors. What is clinical epidemiology? At its heart, clinical epidemiology is the science of linking an exposure to an outcome. Examples of exposures could be anything at all, perhaps smoking. It could be an adverse child experience. It could be exposure to a drug. It could be a laboratory value like HbA1c or total cholesterol. But if we give the exposure as a doctor, we sometimes call that exposure an intervention. Examples of interventions obviously are things like drugs, but there are many non-drug interventions such as physiotherapy, psychological therapies, and complex interventions with multiple subcomponents. Examples of outcomes would be things like clinical outcomes such as mortality or morbidity or the side effect of a drug. Patient-reported outcome measures or PROMs might measure things like quality of life or pain scores. Surrogate outcomes could be a laboratory value which in turn is associated with a clinical outcome. We might have health economic outcomes, and there are outcomes called composite outcomes, which are constructs made up of multiple sub-outcomes. I would say a few things about outcomes. They have to be measurable. And in terms of collecting a measurable outcome, then the outcome is either a numerical type variable or quantitative variable. And this is a number. It could be height in centimeters, or it could be a number like HbA1c or cholesterol. It could also be a categorical variable. These are categories that could be binary, like mortality or biological sex, male, female, or it could have several categories in an order, like poor, good, or excellent. This matters, the type of variable, in when we try to describe data or perform statistical tests. Let's recap on study design. If we observe an exposure, those studies are called observational research studies. If we intervene and if we assign the exposure or a drug to a population, those studies are called interventional or experimental research studies. In observational research, we define the type of study as to what is measured first, the exposure or the outcome. A case control study starts with people who have an outcome, such as lung cancer, and it looks back at exposures. A cohort study starts with people who have the exposure first. They look at smokers versus non-smokers and they follow them up over time to see who gets the outcome. A cross-sectional study looks at exposures and outcomes at the exact same time. In interventional studies, we probably all know that the gold standard is the randomized control trial. Randomization removes a concept called confounding, which we will discuss in a moment. So just to tease this out, imagine in the 1940s, clinicians were noticing an association between smoking and lung cancer. This was anecdotal. So Dallin Hill in 1950, they performed a research study. They started with the outcome first. They found patients who had lung cancer and they asked them if they smoked before the exposure. For the comparison group, they observed another group that was age and sex matched, and they asked them if they smoked before. The risk difference between the two groups was assessed, and this is a case control study. One obvious bias here is recall bias in this study design. So the tobacco lobby jumped on this bias and they said that the association was spurious. So the study investigators decided to do a new study from 1954. They measured the exposure first in smokers, and they went on to measure the outcome in smokers and non-smokers. So they waited until lung cancer developed. So obviously this takes a long time to perform a cohort study like this. Ultimately, the risk difference in those two groups showed that there was association of smoking with lung cancer, and this ultimately showed the causal association of smoking lung cancer that we know of today. I will not go through the concept of causality in this presentation, but all observational research is prone to something called confounding. Confounding is when a hidden variable influences both the exposure and the outcome. And if an association is found between an exposure and outcome, well, it could be the confounding variable that is the causal factor in the association chain. And that's why we don't rely on observational research alone when deciding on treatments, especially medications for patients. It is the reason also that we say association does not equal causation.
So enter the randomized control trial, the gold standard of testing our interventions and therapies. Randomization splits a population into an intervention group and a control group. If done appropriately, randomization eliminates the concept of confounding, because the confounding variable is randomly assigned to the treatment group or to the control group. So we only believe treatments if they come from well-conducted randomized control trials. What about systematic reviews? They are studies of studies. If we're looking at a treatment or a drug, it could be that a systematic review of randomized control trials would be the best study design, but it could be a systematic review of cohort studies if we're looking at a prognostic question.
Hierarchy of evidence.
So we can get a sense from the studies that we've discussed that there's a hierarchy in evidence, a hierarchy in believing that the association between the exposure and the outcome is likely to be true. We can see that a randomized control trial might be more believable than a cohort study, and a cohort study would be above a case control study. Above a randomized control trial would be a systematic review of randomized control trials. Below a case control study would be a cross-sectional study when the exposure and the outcome are measured at the same time. This is called an analytical cross-sectional study. Below that come other study designs like ecological studies where data is collected at a population level, not an individual level. And then below that will be case series and case reports, which are really just anecdotes in terms of believing an association. And then below that again is opinion. So that means that evidence-based medicine, decisions based solely upon authority, it really isn't what we're looking for in modern healthcare. We will also hear about the grade system and other ways in which we can classify the strength of the evidence for a recommendation about a treatment or a diagnostic test or a risk factor. That's a structured way to rate the certainty of evidence and the strength of our recommendations. Even randomized control trials can be rated down if they are biased or if they're imprecise, and observational studies can be rated up if their results are very compelling. All our clinical guidelines will have a nod to grading evidence.
Okay, let's take a step back. There are obviously many more research designs that are crucial in medicine. There's qualitative research that explore meaning and experience, and then there are highly controlled biomedical studies and lab-based studies. But in the middle, randomized trials, the experimental research, and observational studies, particularly cohort studies, well, they answer some of the crucial questions we have about treatment and risk factors. Just to say something about the other research methodologies. Qualitative research methods aim to explore attitudes, experiences of research participants. Qualitative research methods might be things like interviews, focus groups, ethnography, and they really do help us provide insight into patient experiences, into healthcare processes, and into the cultural context of healthcare. Alongside clinical and epidemiological designs, though, there is biomedical and laboratory studies, and they investigate all sorts of things, the mechanisms of disease, diagnostics, drug interactions at molecular, cellular, physiological levels. And they can be very important, but they really should never impact clinical decisions with our patients until formal epidemiological studies have outlined the evidence base and before they're performed. Increasingly, we also hear about quality improvement science and quality improvement methods to help local practices, like plan, do, study, act cycles. They often evaluate structures, processes, outcomes in real world practice. Technically, it is not research. It is about identifying what is safe, what is high quality, and it supports improvements. But more on that later. So it's great to have a revised study design, but we can now see that certain study designs can answer certain types of research questions. If we have a therapeutic question, does this drug work well? Well, the best research method to answer that question would be a randomized control trial or a systematic review of randomized control trials. If we have a prognostic question or a question about a risk factor, well, the best research method to answer that will be a cohort study. And if we have a diagnostic research question, well, that could be answered through several methodologies, starting with a cross-sectional study, but the impact of that could be tested through a randomized trial at a later date. How do you practice evidence-based medicine every day in clinical practice? Well, there are 4 steps, the 4 A's of evidence-based medicine. And the first step is to ask a focused clinical question. To do this, we need to understand the PICO construct. So P stands for a population or patient group. I stands for intervention or exposure. C stands for a control or a comparison. And O stands for outcome. So when we have a clinical query, we use those PICO constructs to then come up with a focused clinical question. So for example, you might in your clinical work in an emergency department or general practice come across a patient who's taking opiate substitution therapy or methadone. And you might just wonder, what is the evidence base underpinning this? Does it work? A focused clinical question in this setting might be, in adults with opiate use disorder, does opiate substitution therapy reduce the risk of death compared to no opiate substitution therapy? The 4 PICO constructs are in this question. Step 2 would be acquiring the evidence. We don't have to reinvent the wheel. We can use trusted resources like, highly valid guidelines from NICE or from the Irish College of General Practitioners or from BMJ Best Practice. Many of us use trusted secondary sources of information such as UpToDate, and we can look at individual trials through that. I'm not going to get into PubMed about how we can find individual trials, but in our search criteria, we can use the study design like randomized trial or the PICO constructs like population, intervention, outcome, or we can use Boolean operators like and or not, and collectively we can find trials using those search terms. I'm also not going to get into artificial intelligence, which has really changed how we acquire evidence. So let's say we found a research study. The third step in evidence-based medicine is to appraise that research study, and there are 3 components. The first step is to look through the methods section of the paper, and that's to look at whether or not the study is valid or biased. If the study is biased, should we even believe the result coming next? The second step of appraisal is to look at the results in the results section. Are the results
statistically significant? If they are, what is the effect size of the risk difference between the groups? Are these clinically important to you as a doctor and to the patient? The third step is about applicability. Can I apply this research study to the real world, to the patient sitting in front of me? The fourth step in evidence-based medicine is the process of applying that decision in clinical practice and also assessing the process overall. Guidelines might recommend something, the result of a clinical trial might recommend something, but your patient's situation and priorities might say another. So evidence-based medicine is about shared decision making, so putting the patient preferences, your clinical experience, and the evidence all together. Why is evidence-based medicine so important? Well, the entire edifice of medicine is on the line. Here are three very quick examples. We have a systematic review from 2017. It is behind a paywall. It stated that clinicians rarely had accurate expectations of benefits or harms, with inaccuracies in both directions. But more often, clinicians underestimated harms and they overestimated benefits. A 2020 study looked at GPs' knowledge of evidence-based medicine. The absolute benefits and harms of treatments was poor, with inaccuracies of a magnitude likely to meaningfully affect clinical decision-making and impede conversations with patients regarding treatment choices. A third study of over 500 GPs in the US showed that clinicians consistently overestimated disease risk. In the study, it stated, in scenarios commonly encountered in primary care practice, practitioners overestimated the probability of disease by 2 to 10 times compared to scientific evidence, both before and after testing. Wow, evidence-based medicine really matters, because if we do not understand the evidence, well, that erodes trust in our entire discipline, and it arguably also prevents the concept of informed consent happening itself. Regulators, such as the Irish Medical Council, highlight this in their latest guide to professional conduct on scholarship. Doctors must search for the best information and evidence to guide their professional practice. Now, there are many limits to evidence-based medicine, particularly in general practice. Our patients in general practice often have multiple medical conditions, are on multiple medications, and they don't fit neatly into the trial populations from which the evidence often derives. So particularly in general practice, we live in a world of uncertainty in relation to evidence regarding risk factors, treatment, and diagnostic tests. Evidence-based medicine does not always have the answer, but it does provide tools to us to support our decision-making with our patients. And it also allows us to accept uncertainty where that exists. I have links to resources and books on evidence-based medicine below. And that's it. That's the end of this crash course on the basics of evidence-based medicine. In the next video, we're going to look at therapies and treatments in medicine. Thanks for watching.